You know, for decades, when we talked about heart failure, it all came down to one single number, a score that was basically a report card for your heart. But now, a major new clinical consensus from the world's leading heart experts is telling us it's time to look way beyond that single grade. Okay, let's get into it. What if that one number, the very measurement we've built our entire understanding and treatment of heart failure around, isn't nearly as solid as we thought? I mean, what if it's been leading doctors and patients down a slightly wrong path? That's the big provocative question we're digging into today. So, to really get why this is such a huge shift, we first have to understand the number itself. For well over a century, cardiology has pretty much hinged on this one single metric to grade how well a heart is working. And that number is called the left ventricular ejection fraction, or LVEF for short. So, think of it this way. Your heart's main pumping chamber fills up with blood, and then it squeezes. The LVF is just the percentage of that blood that gets pushed out with every single beat. Higher percentage, stronger heart. Lower percentage, heart failure. Seem pretty simple, right? And believe me, this was not some fringe idea. The entire field of cardiology has been obsessed with measuring LVEF for over 100 years. The story starts with these rough estimates way back in 1918, moves into more invasive methods in the 60s, then to the rise of the echocardiogram in the 70s, and all the way up to today's gold standard, the cardiac MRI. Through it all, LVEF has been the star of the show. But here's the twist. The tool that we use most often to get this all-important number, well, it has a fundamental problem with precision. And that, it turns out, has some absolutely huge consequences. See, this is where you hit a critical trade-off. You've got the cardiac MRI, the gold standard. It's incredibly precise, super reliable, but it's also really expensive and just not available everywhere. So for most people, the go-to test is the 2D echocardiogram. It's easy to get, but its results can be all over the place depending on who's doing the scan and who's reading it. So, how much variability are we actually talking about? Well, a huge clinical trial called STITCH looked at this exact question, and they found that the average difference between an echo and an MRI measuring the exact same heart was 7.3%. Now, that is not a small rounding error. That's a significant gap. And that 7.3% difference, it's not just some abstract number. It has massive real-world consequences. The researchers basically concluded that up to a quarter of the patients in that study might have been misclassified. Just think about that for a second. That means people could have been excluded from getting a potentially life-saving therapy, all because of a number that was, well, kind of shaky. Okay, so if the single number is flawed, what's the alternative? Well, this new consensus argues that we need to stop looking at a single snapshot in time and start watching the movie. We have to focus on the story that the number tells over time, its trajectory. This right here is the absolute core of the new thinking. A single LVF measurement of, say, 45%, it doesn't tell you that much on its own. But knowing a patient went from 30% up to 45%, that's incredibly positive news. And knowing they went down from 60% to 45%, that's a real cause for concern. The direction, that's the important data. So this new approach encourages doctors to think in terms of 4 key paths or trajectories. Is the patient's heart function recovered, meaning it's back in the normal range? Is it improved, getting better but maybe not all the way there yet? Is it worsening over time, or is it just unchanged? Each of these paths tells a totally different story. And this is exactly why it matters so much. The research is crystal clear. A patient's trajectory is a powerful predictor of their future. The data shows that patients with a worsening LVEF have the highest risk, while those whose function is improving, even just a little bit, have a much, much better outlook. It's just a more dynamic and, frankly, more accurate way to see what's really going on. Now, this focus on trajectory doesn't just change the diagnosis, it completely changes the treatment plan, and it lets doctors act way faster and a whole lot smarter. This is where things get really exciting. Okay, so historically, treatments were put into these neat little boxes based on those LVEF scores. Old school drugs like neurohormonal blockers worked great for patients with a really low LVEF, but their benefits kind of faded as that number went up. But now, check out the newer classes of medicine. Drugs like SGLT2 inhibitors and MRAs are showing really strong benefits across the entire spectrum. This is the absolute game changer. It means that a patient's access to some of the best, most modern therapies no longer depends on hitting some precise, but potentially flawed LVEF number. It basically uncouples the treatment from the tricky measurement. And all of this leads to a revolutionary new playbook for doctors. The advice now is, look, if a patient comes in with clear symptoms of heart failure and you confirm it with a simple blood test that measures heart strain, you don't wait. You don't wait for that echo. You can start life-saving treatments like SGLT2 inhibitors and diuretics right away. The LVEF measurement comes later, and it's used to help fine-tune the rest of their therapy, not to hold it up.
All right, so just when you think you've wrapped your head around all this, the research throws one last absolutely fascinating curveball, one that challenges pretty much everything we assumed about what makes a good score. I know, it sounds crazy, right? We've always been told that when it comes to LVEF, higher is better. A strong pump is a healthy pump. But what if that's not the whole story? What if your heart's report card can actually be too good? Okay, take a look at this chart. This is honestly one of the most stunning findings in the whole report. It shows your risk of mortality based on your LVEF. And just like you'd expect, the risk is high when the LVEF is low, and it hits its lowest point in that healthy 60-65% range. But then something really weird happens. As the LVEF gets above 65%, what we'd call supernormal, the risk starts climbing right back up, creating this very distinct U-shape. And this isn't just some random fluke. It turns out patients with these super high LVEF numbers have a very specific profile. They tend to be older, more often women, they often have smaller, stiffer heart chambers, and they have a higher risk of non-cardiac death. It's a whole different and surprisingly high-risk type of heart disease that we're only just starting to wrap our heads around. So where does all of this leave us? Well, it's pointing to a future of heart care that's way more nuanced, much more dynamic, and ultimately a lot more effective, precisely because it moves beyond that one single static number. So the key takeaways, the new rules of the road from this global consensus are pretty clear. First, classify heart failure based on its trajectory, not one snapshot. Second, diagnose with symptoms and blood tests so you can start powerful new drugs without delay. And finally, let's shift our research to focus on understanding the heart muscle itself, instead of just obsessing over the imperfect number it generates. Ultimately, the heart's report card is being completely rewritten. It's no longer about a single grade frozen in time. The most important question is no longer what's the number, it's where is it going? And figuring that out is changing everything.